Thank you for that generous introduction. And yes, to those that are in here, out there, and joining virtually, I appreciate your attention and thank you for coming to this. As the dramatic title might sound, AI to survive AI, it is exactly that. We want to use archival information to survive this initial wave of artificial intelligence. So let's dig into this. So first, disclosures. I've been on the Roche Executive Council helping with some of Roche's initiatives in the laboratory setting. And it's not been paid, but I do work for them, so it's a disclosure. And then today's objective. So what we want to do is talk about the background. Where are we currently with artificial intelligence? How does it affect us in a daily practice? The FDA policies on AI that we currently have out that are a work in progress. Specific to my world, we'll talk about laboratory archival information systems. What are they? How they can be improved to meet this demand. We'll talk about the inclusive data structures that are needed within these laboratory archival systems to meet that demand. And then these lab AI frameworks that we can use in the future. And that'll lead us to the future perspectives of where we're going and what to watch out for. So background about me, as I was introduced, yes, I'm a APCP board certified pathologist, also certified in hematopathology as well as clinical informatics. I'm a practicing academic hematopathologist, and that's what takes a lot of my time. And if you watch the YouTubes, you probably know Tabitha, the microscope over here, and she is a very good friend of mine. And so I don't talk to her too much, but I use the microscope every day. And so that's unfortunately what kept me from being able to travel, is that I've been on service taking care of patients in the lab. So I also am the director or future director of the Clinical Informatics Fellowship here at UC Davis. It's one of the more unique informatics fellowships in that it's housed within the Department of Pathology and Laboratory Medicine. We are very proud to say that. I'm currently the associate director. I've been in that position since 2018, and so I'll be moving to the former director this July and onward. So looking forward to those opportunities. When I first started, I had a great interest in machine learning and its capabilities, and started a machine learning working group locally here at our campus in 2017. Obviously, the pandemic kind of shook that up a little bit, but now it's been morphed into AI stuff. And I'm currently sit as the LIS director for our laboratory for the EPIC Beaker module. And then, as mentioned earlier, here's that one of those publications in Nature Communications that we're all very proud of. That was a group effort, a collaboration of others. So I've got some experience in this world, both as labeling and performing the models. And so I think it's a good place to sit and discuss where we are. And so, if you look around in 2024, AI and the word AI is relatively ubiquitous. It gets mentioned probably on a daily basis for most folks attending this conference. And we have user accessible engines. Some of them are newer companies like OpenAI and Hugging Face that have allowed for hosting of these models and allowed interactions with them. Some to generate funny pictures, some to generate emails to somebody, etc. We've all hopefully have used some of these services and seen their power and how kind of fun they are to interact with. And of course, we have our old guard, our players that have been here for a while, like Google, Amazon, and Microsoft, that also offer additional AI platforms and services for users to interact with. And again, most of these come with some fees that you have to pay to operate them, but some of them do offer free options as well. And then, of course, our good friends, the frameworks down here, focusing on SAS and R, they have recently, in the last couple of years, released their sort of machine learning and AI type engines to their data sets, so that you can do more than just GLMX modeling in SAS. And of course, you have Databricks, TensorFlow, PyTorch, etc., that allow for some of the coding platforms in the back end to produce these models. So these are all readily available, easy to access, and thankfully relatively easy to learn. That's a relative, depends on what your scope is for computer programming. So again, you probably have seen this chart 100 times, and for various different topics. And here it is about AI. And so in 2024, the current hype model is showing that AI is at that peak of inflated expectations. It's sitting right there at the very precipice of that wave where everyone is pumped about it and all the potential aspects that it can do. And I certainly am there as well. So don't take this talk as something that's derogatory towards AI. In fact, I support it. But I think it's important to know that being here is not over here, which is where we want to be, the plateau of productivity. So machine learning is starting to creep its way there as we've gotten our understanding of it better and better. I think that a few years ago, machine learning was definitely up here at the peak of inflated expectations. And then what we realized is that since data is the key to this thing being successful, that it went down to this trough of disillusionment because we realized we had to spend more time focusing on the data acquisition, the data procurement, and data accuracy before you can initiate it into these machine learning models. Because just because you can create a machine learner that can detect a cat and a dog or whatever it's going to do, etc., doesn't mean it's actually doing the intended function. We didn't realize that till a little bit later, and now we have our data sets that are a little bit more fleshed out. And thanks to various websites out there that host data sets, most folks can get access to some of these to do their own machine learning models that can translate into AI. And when I say translate to AI, of course, I mean this. And you've noticed I have not used any Dolly images in here. I'm trying to keep this kind of old school, not the Luddite old school, but own graphics. And so this wonderfully crafted Microsoft art image is trying to show you that statistics are the building blocks of machine learning. So as you get to machine learning, you've had to use some sort of stats program or stats system to help generate your machine learning models. The model's kernels and their outputs, et cetera, and their predictive natures help with artificial intelligence. And so all these sort of stand on top of each other, and they have to be developed in sequence to get the top goal of artificial intelligence in line. And so I think that's one of the things that we will discuss today is how this part is often the focus, the artificial intelligence, the AI, it's the buzzword, but they often ignore the underlying principles of statistics and machine learning. And this, don't worry, is not a statistics lecture. It's just to bring it to your awareness. So, where does the FDA lay its hand in this? And so currently the FDA is trying its best to harness AI and make it accessible with the same time keeping it safeguarded. And of course, since this is some of the initial rollouts, we've only got a few applications in the health world that have gotten FDA approval. Most recently, a sepsis model got FDA clearance. And so people are very excited about this. And these frameworks will likely develop over time. I think what we see today is likely the sort of beta draft of where this thing will be in 3-4 years as we get a better understanding of it. But specifically what they've done is they've classified artificial intelligence under the domain of software as a service, and specifically software as a medical device. And so with that, you need pre-market approval. And so pre-market approval, or PMA, is something that in the lab we're getting very familiar with as they sunset LDT type testing. And this cost can range. Some things are relatively inexpensive, big quotes on relatively inexpensive, $30,000. But some things can get extremely expensive, up to over $500,000 for your pre-market approval. So it's non-trivial. And it's a process that takes a lot of time, energy, and money to complete. And then, as we know from building models, and I assume that most folks in this room at the informatics level and the biostats level, we help build these models, we put these in place. And when we iterate these models, sometimes it can be done pretty quickly. However, when we do it in this guise of the FDA with the current policies, those will need another thumbs up or approval from the FDA. And so the big highlight points that the FDA wants us to consider is, how are we going to collaborate to safeguard public health with AI? How are we going to advance the development of regulatory approaches that support innovation and not hinder it? Promote the development of harmonized standards, guidelines, and best practices and tools. That's still a very Wild West environment. And then, of course, support the research related to evaluation and monitoring of AI performance, which I think is one of the topics that is of most interest to me. And specifically on that topic of monitoring the performance, what they want is they want us to support the research related to the evaluation and monitoring of this. And so how do you identify bias? How do you prevent it from being introduced in the model? An example might be that you had one medical center label the data set. So that data set is going to be inherently biased to the practices and procedures of that medical center. And so can you then generalize well with that model? Maybe, maybe not. You don't know. But to eliminate some of these biases, we know that having broader label groups can be extremely helpful. But that can be a problem in healthcare because labeling healthcare data, gets cumbersome due to, of course, HIPAA and protection data information that we need to keep secure. And then also with the idea that it is costly at the medical level to label some of this data. But the goal of all this is to reduce the risk. And so the idea is that the less bias you have in your model, hopefully the more generalizable it will be and work with the general public, and the risk will be decreased. They want us to consider health inequalities associated with the use of this. And so you can imagine very quickly that if you got the latest iPhone and an M3 Apple laptop and all the bells and whistles, and even maybe an Apple Vision Pro, which I hope you're not watching this in, because that might be confusing and disorienting. But if you are, kudos. Anyway, the point is there's going to be folks that have access to this technology, that have access to the tools, that can pay OpenAI, pay whoever to do this for them, and there'll be those that do not. And so how do we make this equitable, for especially in healthcare, where we know that there are disparities with both access, receiving good care, and then sticking with that care due to social and economic efforts. And so this, of course, goes down into the diversity, equity, and inclusive efforts that the FDA puts out when they're considering their policies on AI. And then finally, monitoring of these AI tools. So after you get this thing productionized, how do you monitor it? How do you demonstrate that these projects ensure the adherence to these standards, ensure that their performance and reliability is good? And like I said, a lot of this stuff has not been formally flushed out, and it's in the working process. So these are aspects that are looking to evolve over time. And at least we have something to start with today. And so, at most and at the simplest view, the FDA wants to interject to make sure that healthcare related AI systems are done in a way that is, as they say here, reduction of bias, they're inclusive, and they have ways to monitor so that we can make sure that these are reliable models. But of course, it'll come at a price, both of time and just actual money to pull this thing off. So as we struggle through this, and as those processes from the FDA get approved and pushed through and changed, what are we going to do on the back end? Well, archival information, the other AI, and archival information, to me, is where AI starts. This is where you are getting your data. And of course, hospital systems generate bulk clinical data on a daily basis. And every day, a hospital is issuing tons of notes, radiology, imaging, and laboratory diagnosis and laboratory studies. And so, this data is usually exported to various structured data warehouses for various tasks. Typically, these go into analytics to look at the hospital's performance, dashboards to monitor certain things like the number of open beds, the number of discharges. A few years ago, those dashboards were used for monitoring COVID. How many patients did you have with it? How many you don't have in the broad community, et cetera. And we probably all remember going to the Hopkins hosted website to look at the map of the world and see all the red dots and sit in terror as we sheltered in place during the COVID pandemic. So dashboards, a great representation of these data warehouses. Of course, these data warehouses are used for quality compliance and, of course, billing, and some of them are used for research, but not all. I think the latter ones are used predominantly and have the most stakeholders due to their importance for the operational of most hospital systems. Well, back in the lab where I sit, that's where we produce most of the structured data within the EMR. And so this is one of the biggest tasks that we run into is when you do want to do some kind of model or statistical model, machine learning or artificial intelligence engine, one of the lowest hanging fruits is structured data. And well, that's where the lab comes in, because when you get a blood test and we get a CBC, we know your white count, your red count, your platelet count, MCV, a whole bunch of stuff. You get your chemistry panel, so we know how your kidneys are functioning, etc. So these are very discrete and easily used in current available data sets. This will change. I think what we see with the large language models is the ability to make inferences on clinical notes or unstructured data. It's still going to be a little bit of a push to get that labeled correctly and into a form that is meaningful for the modeling that we do. But to my point, and again, my bias is from the laboratory, that's the microscope right there, is that we are the bulk of this structured data that is likely going to be going into these machine learning and artificial intelligence models. And it's currently the fastest way to generate these. And so I think I alluded to earlier that one of the most recent FDA approvals for AI was a sepsis model. And most of the values there are coming from the lab, sans the patient's age and gender, et cetera. And so the other part, again, bias to the lab in my world, is that the ground truth usually lives in the lab. So if you want a diagnosis of a certain malignancy, it's going to come from us, or the diagnosis of a certain infection or culture growth, it's going to come from us in the lab. So the ground truth that most people seek for these AI engines lives with us. So I can't make this stress this point more, that the archival information specifically from the lab is paramount as we go forward in these endeavors, and it's something to not be overlooked. So, well, what's the problem? Why am I even talking to you? Well, that's many good questions, but I will only answer a few of those. So currently, with our laboratory information systems, our LIS, if you would, the operation engine of the lab, these are great at looking at specimen tracking. So once a tube of blood is collected on the floor, I know it's been collected, I know it's on that floor, and then I know it's received by my laboratory, and I know that it's on the processor and it's working. So this allows for us to track the specimens. Once they're here, we can write a report, we can put an attestation on that, we can disseminate those results, and then that data can be retrieved for various things such as quality and compliance. And so typically in these laboratory management systems, one of the things they push back to the end users in the data front are the linkage of the storage data, which is not always included in the LIS or the EMR. And so those data that get pushed back to the users are simply to meet these needs up here. And so the gaps that they run into is that they often forget demographic information. They forget some of the other aspects that are sort of not of particular interest to the lab per se in the past, just because it didn't cover these areas of quality and compliance. But what we're seeing is that as this data is being used for these machine learning models, it's very important that this connectedness be flushed out. And examples of this are molecular data, gross photos from our grossing lab, whole slide imaging, which in and of itself, there's probably several discussions on whole slide imaging. It's non-trivial. It's a big project. You have flow cytometry. I'm a hematopathologist, so I look at flow plots all the time. I love my histograms. Fish studies, which is fluorescence in situ hybridization, not studying of the actual fish that swim in the ocean or the seas. Microbiology data, SPAP-IFE, etc. So lab generates a ton of data that is often excluded from the EMR and from the LIS and is handled by other systems, either vendors provided or likewise. And so as a result, as I was mentioning earlier, most of these laboratory reporting systems focus on, the turnaround time. How quickly is this data coming out? What are the total numbers of cases you generate? How many follow-up tasks did you have to do? Did you have to call the clinicians? Were there any errors in the process that occurred, whether you had to put an amendment, addendum, or the specimen was received mislabeled, etc.? We track all of this. That's pretty standard fare for most hospital systems. And you can see a little dashboard here of turnaround times over some period of time. And it's great to monitor. It's a good quality metric. However, we must start pulling in more data from the lab. Since they're going to come to us for that data, we need to be responsible for it. And so what you see down here is an example of one of our dashboards that we've created here that pulls in the derived race and ethnicity from the chart. Of course, as the lab, we're far removed from the patients often, and so we can't necessarily describe who they are, but the EMR and most of our health data systems will have something like that from the clinical colleagues. And so by keeping track of this in our data, we can see the number of diverse individuals that we treat at our institution. We can also look at the gender, and we can look at geographical information. Of course, I'm in the University of California, Davis in Sacramento, and so you can imagine that our geographical capturement area is in that Northern California, Nevada, and Southern Oregon area, as you see there. And so these factors must be included in our data. And so this allows us to get to these lab AI frameworks. Like I said, data quality and connectiveness is paramount. As you connect this data, it allows you to be nimble for the future, for this next wave of artificial intelligence that'll be smarter, that'll be more sophisticated than what we have today. These labeled data sets must include those inclusive features as we described earlier. You need to have lab management software that tackles this process. And this allows you to get to that last point, which is good machine learning practices, the GLBIO, data management, feature extraction, training, interoperability, evaluation, and documentation. All good stuff. So one of the things we've done here, and this is not an advertisement for it, we created a software in-house called Path Search because we didn't have a good search engine. And so it was built out of necessity. And it's one of those systems that sort of became a life of its own. And what I mean by that is this service cross-links all of our historic cases from our prior LISs to our current LIS. This generates over 30 years of pathology data that's all in one data set. This data set contains over 1.5 million individual cases. We have hundreds of active users. Of course, this is only at UC Davis, because it's a UC Davis product. and we get about 45,000 successful queries. And most of these queries are completed in less than 2 seconds, which is another nice feature. If those remember using other systems to do searchings, it might take a few minutes. And I remember using Meditech, the old school version, and it would take maybe sometimes 2 hours to get a simple search done. So this allows you to rapidly iterate through this. And of course, we have methods in place to make this research accessible so that we hide HPI and allow this to be seen by our researchers. But the real magic here is not that it's getting just our path records, reaching out to our flow cytometry histograms. It's reaching out to our whole slide image repository. It's also reaching out to our gross photos, and soon we'll have in-house molecular data. And when all of this is collated, it'll be in a one-stop shop engine that you can interact with and pull your data from. So future perspectives, how do we survive this? So as I said earlier, the lab is going to be the key for this data. It's where the discrete data lives, one of the most important data sources we have. And so we need to make sure that it's as inclusive as we can so that when it gets utilized, it is meaningful. It meets those criteria set forth by the FDA, that it's inclusive, that it provides equity, and that we can monitor it. And what we see in the landscape today is that out of the top 500 companies in the S&P 500, or the S&P 500 in general, almost half of them, 179, discuss using AI in the near future with their shareholders. There's a huge interest coming from the corporate side. Healthcare is obviously actively pursuing this endeavor. And one of the things you got to watch out for, and this is from the SEC, the Securities and Exchange Committees, is this term called AI washing. And this is where I see the surviving part. This initial wave of hype that's coming down to us is going to be pushed often by folks who don't do what the AI is going to do. They see the product, they say, yes, AI is good, therefore we need to use it. So they purchase it, implement it, and the end user might not really want to have access to it. And so we have to watch out for this, because I think there's going to be a battle in the next 2 years of this sort of AI snake oil, or AI washing, as they call it, where we get promoted and entangled and enlightened by some of these potential opportunities that AI can provide. But the data isn't there yet. And so it won't be a good model, and it won't be something that'll be utilized by the users. And that brings us to this 4Ds concept behind AI. And of course, the data is the most important thing. Healthcare data is abundant, but it can be difficult to disseminate, as for the reasons described earlier. Federated learning helps with some of this, because you can share just the model back without disseminating the data that's within it. And the gold standard guidelines to help with this, which are still being put together. Dividends. This is super important for all of us, which is return on investment. So you purchase this expensive AI tool. What does it do for the bottom line? Is it actually going to help? Or is it just putting it there so that we can advertise that we have AI? The distribution. How do we implement these models? And I think that I see this all the time when I read journals for the last couple of years that have machine learning and AI, especially in the world of pathology, where they'll show very cool products that can do really nice things. But how do I get access to it? How is this distributed? Usually these are one-off systems running on a local Linux server that are compiling this information, and it's not very distributable. And then ultimately the delight. And that's where I think we see this with OpenAI and the ChatGPT environment. You can use it. It's pretty easy to use. You can walk in and it makes sense. And the end user, us interacting with it, are fairly happy with what's going on there. And so, as I said earlier, there's a lot of companies looking to go in this direction. And I think the C-suites are going to be making these decisions for us. Unfortunately, the end user is going to be the one who gets to decide how delighted they are with this information and these tools. And we have to protect ourselves against that kind of purchasing and that kind of onslaught of AI as it comes down to us. And ultimately, creating this ethical development, this deployment and maintenance of these medical products that incorporate AI in a safe way, with our data being connected, making sure that our data warehouses include as much information as they can so that we can create models that are not biased, that are inclusive. And this ultimately ensures that patients get access to these products and that they're safe and they're effective and they work for their intended uses. And so, to wrap it up, these are what we covered, the background of where we are today, some of those FDA policies, what laboratory archival information systems are, how do we create that inclusive data structure through data connectiveness, how that leads to the frameworks for lab AI so that we could have these informations connected, and then ultimately getting to that plateau of productivity after this initial wave that we have to survive of the AI onslaught being the buzzword and the new hype out in the C-suites of our organizations. And here's some references. And then ultimately, I want to say thank you to all of you out there, the ISCB, the GLBIO, for providing me this opportunity to speak. And I will be quiet and look at the chat and see if we've got any questions. The good news is for me, all I can see is the screen. So this room might very well be empty, which is fine. I can understand a virtual presenter is not the most exciting person, but any questions about what just got bombarded upon you?
Yeah, we do have a question in person here, so I'm just going to repeat it because the microphone won't pick it up.
We tried earlier. Okay.
So the question is, are you concerned about generative AI getting stuck in its own feedback loop where it ends up generating more nonsense from its own AI nonsense?
I think that there's two ways to look at that. In healthcare, I think that, we can keep ourselves a little bit safer just by the way we interact with it. But I think in the general public, yes, it is a danger. I think that what you see right now is that there are many media outlets that are using generative AI to create, clickbait, as you'd call it, to click on stuff in your news feeds and whatnot. And so I think that can have a detrimental impact, as if it hallucinates in there and then retrains on that, you start to go down a not dark path, but just sort of a non-existent pathway. You've imagined the information. I'm hoping that in healthcare we can prevent some of that, because I think the utilization of generative AI within healthcare is going to be multifaceted. I think there's many aspects. One of the ones from pathology I think of a lot is, how can I take my pathology report and rewrite it in 4 different ways? One for the clinical team so they can read it, one for the billing department so they can bill all they need to, one for another pathologist, which is kind of how pathologists write, and then one for the patient. So when they read it, it makes sense to them in a responsible way. And so those aspects I think are fairly safe. But if you start to have Gen AI write patient notes based on very little features, that would be dangerous. And hopefully that will not be something we see. But it's a great question. Great question.
The same person has another question, so let me repeat that here. Okay, cool. So the question is essentially, you mentioned how AI is going to need a lot more metadata to kind of improve. And the question is if you have any concerns about patient privacy surrounding that metadata, whether that's in the IRB process, and then also if there's any ways for AI to improve without the use of metadata.
All right, I'll tackle the first one. As I mentioned in the beginning of the talk, in 2017, we started working on machine learning projects. And when we present these projects to the IRB, they really didn't know what to do with them. It was sort of this, like, you're going to do what? You're going to take this and put it through a machine learning, like a kernel model, statistical model. So there was a lot of confusion around that with the IRB. And so I do think there is risk from both sides. In other words, I think the IRB's goal is to safeguard, and that's a good function of the IRB. Is to safeguard patient data, make sure that products and research is being done appropriately. But I think that there's also a little bit of a knowledge gap currently within those organizations by having experts within the AI and machine learning field sit there to understand how this could be manipulated or how it could be attacked in some way. And so I think that there's going to be an evolving process, just like we see with the FDA. They have some policies out now. They're not completely polished, but there's something, and it's likely going to take some time to get this to a full suite. And yes, there is a huge risk with AI, machine learning, and these data sets. We're seeing it in the news every day about health systems under a cyber attack. Now, usually this is attacking their operational systems. It doesn't seem to muck too much with the with the research elements, but still the risk is real. And so the safeguards of this is one of those reasons why the distribution of this data and trying to prevent bias is extremely challenging in healthcare, because it is much easier to keep that data set secured and local within your VPN and everything, and not have it live on a cloud, but only your labelers from your institution have access to it. And as soon as you open that up, that's when you do open up to risk. And so I think that, I don't have a good hardware software solution yet. I think federated learning has some promises to help with some of that, and reduce the amount of information that has HPI in it that's being transferred back and forth. But I do think it's a risk. The next part of the question was synthetic data and how can that help with some of this. And I think, if I remember correctly, and synthetic data, I think, is a very good tool. I think that, some of its limitations, of course, might be that if you're trying to synthetically create data, it's likely because you're missing that data element in your data set for some reason. And so, it's probably helpful to a degree, but I don't think it's going to completely eliminate bias that you might introduce or might be able to avoid by having real data from a real patient subset in which you are missing within your data set. But I do think that synthetic data has a home, and I think it definitely has a home in the prototype of model phase, where you can quickly spin up to see if your kernels are working and producing good functions. And so I hope I answered that question. If I remember the second part of that question